Hi, everyone. Thank you so much for joining us for today's CCSP webinar, Interpreting Endoscopy and Pathology Reports. You all know me, but I'm Elsa Weltzine, Program Manager for CCSP. We'll give everyone just a moment to get their audio connected, and then I'll go ahead and introduce Dr. Jen Kolb, and we'll get started. So we'll just give it another 15 seconds or so and we'll get going. And good morning and thanks for greeting us in the chat, Victoria. If anyone else would like to introduce in the chat and which clinic you're joining from, that's always great to show our presenter where everyone's role and position and where they are in Colorado. All right, we have about 11 folks on, so we can go ahead and get started in just a moment. Dr. Kolb will be pulling up her slides and she can further introduce herself, but some of you might be familiar with her. She was a fellow at the University of Colorado, and that's when we had the opportunity to start working with her as a GI fellow, and she's been a member of our medical advisory team for CCSP for the last few years. And now Dr. Kolb is an assistant professor of medicine and gastroenterologist at the VA for the greater Los Angeles area. And she's also has a position at the David Geffen School of Medicine at UCLA. So without further ado, I'm going to turn it over to Dr. Kolb. And as we're going along in her slides, feel free to ask questions in the chat and she'll make sure to answer those. We'll have time for Q&A as always at the end, and you'll also have the opportunity to come off mute at that point if it's easier to ask a question that way. So Dr. Kolb, I'll turn it over to you.
Thank you, Elsa. Thank you for the invitation to speak today. Hi, everyone. Great to see so many introductions in the chat. I'm just looking here at the different clinics that everybody's from, and this is really great. So as Elsa mentioned, I was in Colorado at University of Colorado for 3 years. So I've worked with the CCSP, and I do know a little bit of the region, and I'm excited to speak with you guys today and really just review really how you can best understand your patient's endoscopy and pathology reports. So feel free to put questions in the chat along the way or save them, and we can go through anything that comes up that you guys are interested in talking about. So, and if anyone can't hear me, let me know, but I am going to get started. So the objectives for my talk today are really to go through the different components of an endoscopy report. I'll say that every single institution, GI, endoscopy lab has a slightly different way of compiling the report. So I'll just go through what are some of the key features that everybody should know. We'll go through the main sort of bread and butter of GI, of gastroenterology, screening colonoscopy is polyps. And so what we have to know about polyps is what are the kinds of polyps, which polyps are more scary, do we need to think about other considerations, and then how do we read a pathology report and what are the key components that matter. So this is actually a really nice checklist of the key subject areas that are supposed to be included in a colonoscopy report. And this was published in the GI Journal in 2007. And these are things that you are all very familiar with. What's the patient information? What's the patient's risk? Different details related to the procedure. So the indications, the technical description, what was the finding, the assessments, what was done, so what interventions were done during the procedure, what's the follow-up plan, and then what's the pathology. And we'll go through each of these individually. So this is an example from University of Colorado. This is an actual report. And again, there's different software, so yours might look different, but there's a few key things that will always be included. So the patient, you need to have identifying information, so the name, the date of birth, age, gender. You may wonder why we include the instrument name, but Each scope that is used, so each piece of equipment during the procedure has a specific number on it, and we always record which one was used in case something happens, like in case there is an infection or an outbreak or something where we have to trace it back. The time, the date of the procedure, whether it was done as an inpatient when the patient was in the hospital, or most of our cases are as outpatients. And then all the different components. Why was it done? Who did it? What medication was given? So this is just an example. But you always want to include things like patient demographics and history, right? So these are kind of going into more detail with that section, the gender, the medical record number, and these are usually identifying information. So, you know, of course, we're HIPAA compliant. These are things that, that the patient is identified by. In terms of how we assess patient risk and comorbidity, so, you know, every clinic has a slightly different setup, but there's two different ways that you can do a colonoscopy or an upper endoscopy. One is by having the GI doctor do anesthesia, something called conscious or moderate sedation, right, through the IV. And the other is when we set these cases up with the assistance of anesthesia. And a lot of that comes down to how healthy or how sick your patient is. So we have a standard classification system through the American Society of Anesthesiologists. This is called the ASA. And this is essentially a way for any physician to say, okay, this patient is this healthy and can undergo this procedure without the assistance of anesthesia, or, you know, this patient has heart disease, lung disease, they're maybe an ASA 3 or 4. So you can always pull this up on Google, this table, and it's again, a classification system to indicate the comorbidities or how sick the patient is. Typically ASA 1 or 2 we can do with moderate sedation, and ASA 3 or 4 needs anesthesia. But again, this is very dependent on the practice setting, and you know, you may have had other experiences, just kind of systems dependent. And then what are these different levels of sedation? Minimal, moderate, deep, general anesthesia. You know, we have different ways to sort of specifically identify what level of sedation it is. You know, not necessarily important to know all the details, but again, I would say the main difference is whether or not this is moderate sedation, which is given by the GI doctor, the endoscopist, or if this is, you know, actually anesthesia given by an anesthesiologist during the procedure. So the next thing, now that you've assessed the patient, you kind of know the patient's demographics, you've assessed their risk. The next thing that's important to look at on the colonoscopy report is why was the procedure done? And this is something I know everyone's dealing with in the clinic, which is figuring out what's the indication, and that's typically how we bill for the procedure or get authorization for the procedure, and how we explain to our patients why you have to come for this case. So the indication is usually written at the top of the report, and you can see here that it says high risk colon cancer surveillance, personal history of adenoma, high risk surveillance, personal history of traditional serrated adenoma, last colonoscopy, May 2015. So this is a patient who had a procedure, you know, 6 years ago. They have had polyps before, and so the indication is surveillance. But there's a lot of different categories of indications, and I like to think of them as 3 categories. So the first is screening. Screening means either they've never had a procedure, so they're age 50 or maybe age 45 with our new recommendations, and never had a procedure. This is their first one, that's a screening. Or it might mean that they had a procedure, there was nothing found, and this is their next screening exam. When you think about screening, there are a few important questions that you have to ask so that you know their risk. So are they average risk? Are they getting their first procedure, their screening, but they have a family history of colon cancer, they have a family history of polyps, or they have a familial cancer syndrome like Lynch syndrome? So anyone who comes in for screening, the indication, you'd still want to know the answer to all those questions. The second category is surveillance. So surveillance means we're surveying, we're continuing to look. And this suggests that there was something prior, and there was something found on a prior colonoscopy. So if I'm going to do a surveillance procedure, what I'd want to know is, well, what was found last time? So like that previous case I showed you, well, the last time the scope was done was in 2015. there were this number of polyps found. This was the pathology. And we have guidelines from all the different GI professional societies to tell us when you're supposed to do the follow-up. So whenever we're thinking of the indication for surveillance, we want to always kind of think back, oh, what did this patient have in the past and how might that inform what we're going to find today? So screening and surveillance, but then there's a third category of indications, which is, well, this patient is actually here for a diagnostic examination. And what that means is that they're having typically either one of two categories. Either this is a follow-up from a non-invasive colon cancer screening test, or they have symptoms. So what does that mean? It's a follow-up. Well, some of you may work in clinics that do FIT testing, fecal occult testing, maybe even Cologuard testing, and those are all stool-based testing. Usually there's some sort of a card that gets sent to the patient or given to them. And then if that is positive, we follow that up with a colonoscopy. At that point, those are considered diagnostic procedures because they're not really screening anymore. The screening's already been positive. But there's also patients who come in, I've been having diarrhea, I have some weight loss, I may be having some rectal bleeding, I think it's hemorrhoids, but I think we should take a look. So those are all like an indication of a diagnostic reason, okay? So those are the major categories for indications, and it's important to kind of keep this straight. And so to make sure in the report that, you'll get a sense in that when you're explaining to the patient or telling the physician kind of why the procedure is going to be done, that we think about the right indication. These are a few examples. Again, the system will sort of report things differently, but the person doing the procedure can type it in, free text. So the first one is a screening. This is the patient's first colonoscopy. So we assume that's probably a younger patient. This is the first time. The second one, here's an example, surveillance. The last colonoscopy was in 2017, and they had a piecemeal removal of an adenoma. So we get the type of polyp, and we get the way it was removed. The third one, this is a high-risk patient. They have a genetic syndrome. And then for the last one, this is a diagnostic exam, right? This is a patient who's having bleeding, change in bowel habits, and so it's a diagnostic procedure. Just some examples, okay? So the next thing that is going to be really important to look for when you're reading the reports is, how did the procedure go? The technical description. And I'd argue this is maybe one of the most important things because this really tells you about the quality of the exam. So lots of people get colonoscopies, but the question is, lots of people can get these done and can look at the reports and can say, oh, I'm done with this, think about it in 3 or 5 or 10 years. But really the way that you know if this was a high quality exam and if they're sort of good for a few years until the next indicated interval is based on how far they went, so the extent of the exam, and how good was the bowel prep. So let's do some anatomy review. So this is a colon. This is kind of, if you imagine a person standing in front of you, this is how things would lay. So starting from the bottom, and we'll work our way up. So the anus then leads into the rectum, going up. And again, this is the way the scope moves, right? It moves up and around. Okay. So then we go into the sigmoid colon, the descending colon. The reason it's descending is because when things come down, they're descending, even though we're kind of going in reverse right now. That's the splenic flexure. Flexure is always the corners, and it's called the splenic flexure because if you can imagine, the patient has spleen sitting right sort of on the outside of that. This is the transverse colon. It's going transverse across the hepatic flexure. Again, this is the corner, the flexure, and sometimes it has a bluish hue because the liver is sitting right there. This is the ascending colon, and then the cecum. The cecum is, depending how you look at it, it's the first part of the colon, but for us doing the procedure, it's the last part of the colon that we see. There is an appendix, right, that is, we can't see the appendix from the inside. We can see the area where the appendix should be, but everybody kind of knows that the appendix is this other organ that some people may have had appendicitis and it may be removed, but the appendix sits in that area. And then the cecum, the thing that you see from the cecum, if you wanted to keep going, you'd have to go through the ileocecal valve. So the most important question is, was the cecum reached? Yes or no? And this is whether or not the procedure was complete. And so again, if we kind of think about this orientation, then talking about how do you know was the procedure complete? So technically they should tell you in the report, but if you have to be a detective and do some digging, I want to give you a few tips of how you might look for, kind of read between the lines rather. So ileocecal valve, what does that mean? Well, it's the ilium, with the cecum. So ileum is the end of the small intestine. So if you go, we always think of valves are kind of like doorways or passageways. So as soon as you go through the ileocecal valve, you're in the small intestine. So of course you can imagine if you made it into the small intestine, you're done with the colon. The colon is the large intestine. And so you've seen all of it. So somebody might not say, I reached the cecum, but they may say, oh, I made it through the ileocecal valve, or, oh, I made it into the terminal ileum. So that means it was a complete procedure. And then the other thing is that the appendiceal orifice, again, the appendix, not the organ, but you'll see that there's this like sort of little indentation where the appendix sits on the outside of the colon. And so if anywhere in the report you see ileocecal valve, appendix, appendiceal orifice, ileum, these are really clues to you that yes, this was a full, complete procedure, which means we can confidently say that they saw the entire colon and this was a complete exam. The second key important thing to really note on the report is what is the quality of the bowel preparation. So I'm sure many of you have a lot of experience with trying to help patients to understand the importance of the bowel prep, with trying to get patients the actual medications that they need for the bowel prep, and dealing with inadequate bowel preps. And this is really still a big struggle for us as a field. And the reason it matters is because it's really, I always tell patients, like, the quality of the exam is only as well as I can see. And so I remind patients that this is really a joint process, that they have to do their part. They have to go through the prep. I know it's not fun. Nobody enjoys it, but it's really the only way that I can guarantee that I can clear the colon for polyps. So this is an example, two different examples. Again, I took these straight from reports. I didn't make these up. So the first one you can see, just focus on the highlighted and underlined. Somebody said the quality of the bowel preparation was good. And that might be how it's reported. The second one you can see, there's a few more, it's a little bit more elaborate. The quality of the bowel preparation was evaluated using the Boston Bowel Preparation Scale with scores of 3, 3, and 3 for right colon, transverse, and left colon. And the total score equals 9. So the problem is that there's some inconsistencies with how people report the bowel preparation, but really it's okay. There's a lot of different scoring systems, and that's okay. I'll just go through maybe the Boston Bowel Preparation Scale because that's one of the more common ones. But there's also Aronchik, the Ottawa, and it may just be also just saying good. So for the Boston Bowel Prep, there are scores that you give from 0 to 3. And you can kind of see, 0 has some solid stool, whereas a score 3 looks pristine and very clean. And you give a score to 3 different parts of the colon, the right colon, the left colon, and the transverse. But you might also just see that somebody just says adequate or not adequate. Someone might say good or excellent or fair or poor. And so we do basically have sort of ways to kind of equalize across the different scores. I think we would say that a Boston Bowel Prep of a 0 or 1 is really not adequate or poor. And a Boston Bowel Prep of 2 or 3 is adequate. And what does that mean, adequate? Adequate meaning like good enough, I'm happy. Well, adequate really means adequate to see polyps, right? Again, the name of the game here is polyp detection and cancer prevention. And so if we can see adequately, the mucosal surface is clean, I can identify polyps, then we'll say, check, this is good enough. Because of course, if it's not adequate, this really doesn't constitute as a colon cancer screening exam, and we probably have to repeat the exam. Again, this is going to be an ongoing battle with patients, and it's not their fault because honestly, wow, this prep is so delicious. I think I'll drink another. Said no one ever. I mean, these preps are not fun. They're just really the worst part of the procedure, but they really are so critical to helping the endoscopist really get a good views of all the different parts of the colon behind folds so that you can find polyps. The second cartoon I really like because some patients, not all, but some will say, you know what, I feel great, what a cleanse. And we do have a lot of patients who get these procedures for constipation, and sometimes this is kind of like a reset for what that's worth. So those are the technical description. And then of course, the other thing you want to look for in the reports once your patients, go through their procedure, the questions they might say is, well, what did the doctor find? So the most important things that we report, of course, are polyps, mass, hopefully not. Is there any abnormality of the mucosa? Was there inflammation? Was there an ulcer? Were there other findings that are benign, meaning like not something to worry about, but something that we would report? So like diverticulosis or hemorrhoids. Okay. This is a picture of diverticulosis. You may see the word diverticulosis in a lot of different, it's fairly common, especially among older people. So diverticular disease, diverticulosis, it's kind of looks like Swiss cheese, but this is a picture of the colon, the sigmoid colon, and you can see if you go straight ahead and sort of over here to the right, this is where the lumen is, so the scope goes. But then there's these big pockets or divots. So these cut out areas, sorry, not cut out, these sort of indented areas are called diverticula. And they're really outpouchings. They're just like sort of mucosal focal breaks in the mucosa, and they're pretty normal and naturally occurring with age. And sometimes they can cause problems and get infected or bleed, but by and large, we just report this when we see it and tell the patients not to worry about it. So the other things that you always want to be aware of is whether or not something happened that was unplanned. So during colonoscopy, occasionally, even though these things may come and go and the patient could be fine, sometimes the patient's blood pressure will drop or their heart rate will drop or something will happen or, you know what, like this, we've removed this polyp and it was a deep cut. I think they're okay, but I want to give a dose of antibiotics. And so reading the report can give you a clue. If they mention that like something was given or something happened that was maybe not typical, then that could clue you in, oh, was there something that the endoscopist is trying to say by reporting this, because this is atypical. And of course, things can happen after the colonoscopy up to 30 days. So now that those are really the key components of going into the procedure, what happens during the procedure. And then the next important thing is really where do you say what's next for the patient, right? What do you tell them is the follow-up plan, and what do they need to be aware of? And I think probably many of you on this call may work with the patient before or after, and oftentimes the patients are completely clueless after the procedure because how many times have I gone to tell a patient after a procedure what I found, what I did? Oh my gosh, they call me later that night. The office calls me, the spouse calls me yelling at me, Dr. Kolb, I can't believe you didn't talk to me after the procedure. What a terrible doctor. And like, I'm so sorry, we had a 20-minute conversation, but you probably have no recollection because of the anesthesia. So this is unfortunately how it goes. So I actually try to tell patients, like, don't worry about it. We'll put it in writing and we'll follow up with you after, because they just don't remember. It's just, that's exactly what the anesthesia, the sedation is meant to do, is, make sure they don't have memories of these events. But in any case, it's really important that we leave the patient and even the primary care doctor, sort of the team, with a good follow-up plan. So things that are immediate important, well, this patient's been holding their blood thinners for 2 days in anticipation of this procedure. When should they restart it? Typically, and this is not a blanket statement and there's lots of caveats, but in general, most people can resume aspirin, blood thinners, all that the next morning. Some exceptions certainly, but I typically just say restart it tomorrow. But sometimes you find something unexpected on the exam and you say, you know what, I want to get some additional testing, some imaging, some blood work. Typically those are written in the report. Maybe refer to another surgeon or a different doctor, have a follow-up appointment. So a lot of that should be written in the procedure report, and that can kind of give everyone a clue if you're trying to figure out what the plan was. Of course, the most important thing is, well, were there polyps found, and what kinds of polyps, and what's next? So now I'm going to sort of move now into talking about polyps for the end of this and for the remainder of our time, because this is, again, really, I think, a huge area of confusion, but also just there's always room for us to, as a team, do better in terms of how we report it and how we understand the findings. So polyps come in lots of shapes and sizes, and hopefully your endoscopist who's doing the procedure is recording all of the details, right? Sometimes they're not, but what I always try to do is say, there was a 4-millimeter polyp in sessile, that's the morphology, in the ascending colon, removed by cold snare and completely removed and retrieved. And that tells you where was the polyp, what was the size. So already you can get a sense of, is it high risk or low risk? I told you it was removed. I said it was completely removed. So we think it's, an adequate resection. And retrieved. Retrieved means that there's going to be a pathology requisition, right? That somebody's going to have to follow up the path. It's rare, but occasionally we'll say polyp was removed but not retrieved. Sometimes you cut it off and the specimen's too small, or you don't really get it and send it to pathology. But that's the most important thing, that you know exactly how many polyps and what was done to them. Sometimes they're biopsied, not removed. You can remove them with a forceps, with cold snare, with cautery, all kinds of ways. So what kind of different polyp types are there? Well, if we're just describing the morphology or what they look like, we typically think of polyps as either pedunculated. Pedunculated is kind of like a tree. It's on a polypoid sort of on a stalk, and I'll show you some real examples. This is just a cartoon. Sessile is more flat, but a little bit of height to it. And then non-polypoid, right? Typically, we think of polyps as polypoid, right? These are tissue bumps or growths in the colon, and we think of them as sort of like, the typical like mushroom or whatnot. But there are polyps that are flat or non-polypoid. And there's two different kinds. When they are non-polypoid, they can be like a little bit elevated or depressed. Those are sort of the worst ones, but something that we keep in mind for when we describe them. So this is an example of a pedunculated polyp. So pedunculated usually has a stalk, and you can see where the arrow is pointing. So it's not flat, right? It does actually look like that typical mushroom. And then I just want to throw out what is NBI or narrowband imaging. Again, so, you may have seen some of this term. You may see something called NBI, narrowband imaging, or eye scan. This is a feature of an olympuscope, if that's what your system, your team is using. And these are essentially light filters. These are fancy light filters, right? And so I just kind of want you to be aware, if you see that, they may say the polyp was examined under NBI. And it's interesting, as you may see, like how it goes from this typical like pinkish, whitish, mucosal appearance. When you use narrowband imaging, it's a red, blue, green light filter, and so it just changes it. So you may be able to appreciate that there's very different, you can really appreciate the vascular pattern, these capillaries here, because they really jump out at you. There's this sort of greenish background hue, and then these bright blood vessels. And so that's something that we use to help us determine what kind of polyp it is. These are actually, this is pretty cool. This is what this is courtesy of Dr. Jeff Kaplan, one of the pathologists at Colorado. This is a gross specimen, meaning like when we cut out the polyps, they then look under the microscope. But before, if we had a picture of these polyps, this is what they looked like. And these are quite old. But you can see on the right-hand side, it kind of does look like a tree or a mushroom where it's got like the stalk and then it kind of grows up into the polyp. So sessile polyps are probably more common, and they're just a little bit raised, and you can still appreciate that they have some height to them. These are just some polyps I've seen. I just grab photos, so they're random, but this is what typical polyps look like. Just for your reference, so everything's super magnified, but I would say that these polyps are about 4 or 5 millimeters, so pretty small. This is a example of what it looks like. Again, the gross specimen that the pathologist would look at. So if you cut out a piece of the colon and you actually look at it, so kind of cool. So we saw pedunculated, we saw sessile, and then the last thing is really flat polyps. So just going to let everybody look at this picture for 10 seconds. And if you are doing this procedure, can you find the polyp? So some people say, aha, here's the polyp. Not the polyp, that's just some blood from I'm not sure what, some trauma. But this is why this is the polyp. And now, in case you couldn't see it, I'm sure you guys are excellent and could definitely identify it. But if you couldn't, now your eyes are adjusting to it. And then I use that really cool NBI narrowband imaging light filter, and you can even better really appreciate it. But part of the reason I wanted to show you guys this is because this is a very large polyp. This is like a 2-3 centimeter polyp. And, these are the ones that we worry about, the large polyps that will certainly eventually turn into, these are definitely precancerous, will turn into cancer. But I'm not showing you this just to say, oh, you need a really good endoscopist. It's actually, you need a really good prep, right? And so these are exactly what we miss when the patient is not well prepped, because you can see how subtle they are. This is another example of a very subtle polyp where a good prep makes all the difference in the world. So we'll talk a little bit about the polyp subtypes, but a sessile serrated polyp is typically they're in the right colon, so in the ascending colon and cecum. And they actually have a characteristic feature, which is that they have a mucus cap. I just pulled these pictures and put them in this slideshow this morning because I just saw this recently, and it's just a great example that I use to teach fellows when I'm training them in endoscopy. Is like, this is not just debris, right? Sometimes we have to wash all the debris, but this just looks like a little bit of like mucus or debris. This is actually a polyp under here. And when we use our narrowband imaging, the light filter, it has this typical red appearance. So these are polyps that have to come out. Again, just emphasizing the importance of a bowel prep. A big sessile polyp, not that's dissimilar than the one I showed you before, but you may see, I just throw this out there in case you've seen this terminology. Sometimes we call these laterally spreading tumors, or LST. It's just another way of saying a large sessile polyp. Okay, so this again is very large. This is from, I'm sort of outlining it, and it goes across over this fold. And so what are the things that are really important to report? So I think if things haven't changed, and Elsa can correct me, I'm pretty sure that the most important thing in the CCSP form is what was the outcome, especially if these are screening, right? Did we find no polyps? Did we find only benign polyps, precancerous polyps, high-risk polyps, cancer? And so I think the most important thing to really keep in mind with polyps is that polyps are the precursor to cancer by and large. So these polyps in the colon, I love this. This guy's like, don't snare me. I swear I'm benign. I'm a young polyp. I've got my whole entire life to have a neoplastic transformation, right? And so this is exactly what we're trying to do. We're trying to find these young polyps and to get rid of them, get them out before they even have a chance to think about turning into cancer, right? So the majority of polyps really aren't cancer, but most of them really do have the potential. And so we have a tremendous opportunity as gastroenterologists and everybody who's working in this clinic setting to really prevent cancer. Colon cancer continues to be the third leading cause of cancer and cancer-related death among men and women. And we've made so much progress with colon cancer screening and colonoscopy with removal, and that's because we know it works. We just got to make sure that everybody does it, and everybody does it with high quality examinations. And the reason that we have such a potential to impact is because this is a very pre-specified pathway. There's no surprises in colonoscopy and colon cancer. And what I mean by that is that a little tissue bump or growth in the colon starts off as a benign polyp, goes from small to large. It develops these mutations or dysplasia, which is precancer, and it eventually will turn into cancer. And I put this red line through the middle because that's our opportunity to intervene, whether we're doing fit testing with colonoscopy, colonoscopy alone. This is really our chance to intervene. Okay. So what are the types of precancerous polyps? What are the things that you may have to report in terms of the findings? By and large, the most common polyp is called the tubular adenoma, okay? The tubular adenomas are probably mostly what you're seeing, but there's some slight variations. There's tubular adenomas that have high-grade dysplasia, tubulovillous adenomas, villous adenomas, sessile serrated polyps, and traditional serrated adenoma. So you might see any or all of these. Again, these are going to come from the pathology report. These are things I can't say during the procedure, but after the procedure, you'll end up getting a pathology report, and you may be following these up. And so this is an example of a pathology report from University of Colorado from one of my patients. You can see in 2019, and things that are important to know, make sure it's the right patient, all of that. It tells you the data was collected, which should match the date of the procedure. And then the final diagnosis. Again, every pathologist, every system may report this a little different, but I kind of just want to orient you to a few things. So there's the clinical history, which they typically, the pathologist will take from what we write. So screening, they had, one polyp. The gross description is what the pathologist would have, and they say oh, I see this one big polyp in formalin. This is what it looks like. So that's just again what they're seeing visually, and then they typically then will take it out of the formalin and they slice it and they put it on the slides and they look under the microscope, and then they give you this final diagnosis. So here they say cecum polyp, polypectomy, hyperplastic polyp, no dysplasia. So this was a hyperplastic polyp. But there's tons of different examples, right? These, again, I just grabbed these straight from pathology reports. So this was a different one. The first one where they said fragments of tubular adenoma, negative for high-grade dysplasia. So these are regular old tubular adenomas, precancerous, but they've been removed now. And the reason I showed you this example is because sometimes when we take out polyps, we put them in one jar, sometimes separate jars. So you might see 3 polyps, 3 separate jars, and there may be A, B, C. Or you might see here, for example, polyps times 3 in A. So it's important to always look at that so you know, well, are they reporting 1 polyp or 4 polyps? So in this case, I think they're reporting 3 polyps in specimen A, and specimen B would be polyp number 4, but it turns out that this was fragments of colonic mucosa with no specific abnormalities. And this happens, right? We are in the business of, or at least I personally am in the business of taking out anything that looks at all suspicious, right? I'd rather take something out than leave it in. But sometimes what we take out is just normal tissue, and that can happen. And so that's fine. It doesn't cause any harm, but it means that I wouldn't think about, bringing this patient back depending on how many polyps I found. I would say that that patient has 3 polyps, right? 3 tubular adenomas, because specimen B doesn't contribute to the polyp burden. And some pathologists will say no high-grade dysplasia or negative, and some just say tubular adenoma, and it's the same thing. It just depends how specific your pathologist is. Okay, this picture may look familiar. This may be, I think we had originally kind of said that this was a good schematic for people to utilize in the clinic to get a sense of this sort of benign to cancer and everything in between. I just wanted to mention very quickly, what are the high-risk polyps? So high-risk polyps are called advanced adenomas or advanced colorectal polyps. And there's some classifications for these, and why do they matter? Well, these are either polyps that are large meaning greater than a centimeter, which is 10 millimeters, or polyps that are advanced by the histology, by the pathology. So they're either big based on what the endoscopy reports, or under the microscope, they have these sort of advanced features. So advanced polyps are greater than a centimeter, tubular adenoma, or sessile serrated, or they have villous features or dysplasia, high-grade dysplasia. And there's two things that matter for advanced colorectal polyps. Actually, there's maybe three. But the first one, what this chart is really indicating, is that these are patients who, if you find one of these, you're not going to say come back in 5 years or 7. And we just got updated guidelines about, when the surveillance exam is. But I just want to call attention that if you find one of these advanced polyps, at a minimum, these patients are at a 3-year interval. So that means that clearly there's data to support that these are high-risk lesions. And I'll just show you one quick paper. This came out in JAMA, a big internal medicine journal, just a few years ago. And really what this paper showed, very nicely done, is that advanced adenomas, advanced polyps, are associated with higher risk of colon cancer and death. And this isn't compared to having no polyps. This is compared to having non-advanced. So somebody who has a 1.5 centimeter tubulovillous adenoma, 1.5 centimeter big, tubulovillous, villus is scary, compared to like a small 5 millimeter tubular adenoma, that person is at a higher risk of cancer and death from colon cancer, okay? And so for that reason, we bring these people back at 3 years. And I'll just show you an example. This is actually, again, it's very difficult to actually appreciate the polyp, but this is the polyp here. This came back under the microscope as a sessile serrated polyp with dysplasia. And it even had a tiny focus of cancer, even though it doesn't really look like a cancer. And so these are the polyps that we really worry about. I wanted to show you guys one example of what cancer does look like in the colon, as a, also just as a reminder why we're doing this for our patients and why we work so hard to prevent these. This was a cancer in the cecum, so at the end of the colon, and you can see it's sort of ulcerated, ugly looking. Typically when I find things in the colon that are bleeding like this, it always concerns me. And so the biopsy of this shows infiltrating adenocarcinoma. Adenocarcinoma is the most common, this is the type of cells that we see, moderately differentiating, and it's arising in a background of tubular adenoma. And so I didn't make up this pathology report, but I included it here because it's a perfect example of exactly why cancers happen. We have a tubular adenoma and it grows into a cancer. And so the pathologist is actually just, nicely illustrating that it's coming from this background of tubular adenoma. So this could have been prevented, right, if this was found at an earlier stage. If you cut out a piece of the colon, this is what it would look like. Again, this is not something I do, but if a surgeon were to, they gave us these nice images. So you can really see that on the inside lining of the colon, this is how the cancers look. And as long as we're just talking about the cancers and the high-risk polyps, the only other thing I really wanted to mention, these are patients with high-risk polyps who should come back sooner. But we also have to think, and again, I'll just mention this in 1 or 2 slides. I just want everyone to kind of keep in mind at all times, what are the other things that matter in terms of this patient's risk and their family members? So we should always think about, and we should always ask about family history at any point. I should ask about it every time I do a procedure. Everybody who interacts with patients should at some point, as we're getting the colon cancer risk assessment or we're following up with them. By the way, anyone in your family have colon cancer? Anyone in your family have an advanced polyp? We talk about first degree relatives as parents, siblings, and children. Family history matters, but what matters most is really first degree relatives. And even though we think that this is important usually before setting the patient up, this also has implications after the patient's colonoscopy. So I'm going to end with an example of something that would be great in a perfect world, but something that maybe is more realistic of what happens. And maybe we can talk about some ways we can bridge the gap. So perfect world, Mr. Advanced Polyp comes to you, gets his procedure done. He has a 1.2 centimeter villus adenoma. So this is an advanced polyp, Mr. Advanced Polyp, because it's over a centimeter, it's large, and it's villus. So either me after the procedure or one of you guys sees him a week later and say, oh, wow, you had an advanced polyp. This is something that puts you at risk. This is actually something that puts your first degree relatives at risk. Oh, you're 54 years old. Oh, you have 2 children, huh? Wow, okay. Well, for you, I recommend that you come back within 3 years because it's advanced. But go tell everybody. And so Mr. Advanced Polyp calls up his sister and he says, hey, I know you're only 44, but I just had my colonoscopy done and I had an advanced polyp and they told me I should just let you know. And, tells his children, they're still young, but for what it's worth, he calls his parents, they've already had their procedures. And that sister goes and she tells her doctor and she's like, hey, I don't think I need a colonoscopy, but I just wanted to let you know, or sorry, the brother, I think is the example I used. But I just wanted to let you know that, my brother had a polyp. So we end up with a young patient getting a colonoscopy and finding a polyp, a 1.5 centimeter tubular adenoma with high-grade dysplasia. So if a 42-year-old brother or a 44-year-old sister, whatever it is, has that procedure and gets that polyp removed, that without a doubt would have been cancer, right? So this is a perfect world. A colon cancer is prevented. And I do include this perfect paradigm because I think all of us on this call are part of this pathway and in some way can really contribute to the goal, which is to kind of connect patients and families and physicians and pathology findings and colonoscopy findings to get this to happen. But we know this isn't what happened, right? The doctor says you have family history. Who knows? Oh, did your parents have colon polyps? And I'm like, my parents can barely use their cell phones, or I don't know if my brother has polyps, but he definitely has colitis, which isn't really relevant. And didn't mom have polyps, or was it diverticulosis? Like, I don't know. It was really bad. She got her colon cut out, and like, oh my gosh, my dad for sure had polyps. He gets a colonoscopy every 10 years, which if you had polyps, you definitely wouldn't wait 10 years. So, the reality is that healthcare is a little bit fractured and we're all sort of operating. Family dynamics are different, but I just mentioned this as a sort of let's all continue to really keep in mind family history and do our part. So what are the takeaways? Hopefully from this talk, you guys have had a good opportunity to really understand that the details matter, right? The completeness of the exam, the bowel preparation, procedure details matter. Everything about the polyps is important. So size, location, were they removed? And then we always want to check the corresponding pathology. This can take, a week or two sometimes, but that's really where the money's at, right? It's what's done during the procedure, but it's what do those ultimately look like under the microscope? And so we really depend on our pathologists for this. And then what are the follow-up recommendations? And finally, when should they get their next colonoscopy? And which chain of family interactions are we going to start? So with that, I'll end. You guys are always welcome to email me if you have any questions. What time is it? I think we still have about 10-15 minutes, so I am more than happy to take questions now as well.
Thanks so much, Jen. And it doesn't look like we have any questions yet in the chat, but I'd encourage you all, this is a great time. If you've thought about anything or anything's coming up as she's been going through all of this information, please put them in the chat. And then in just a moment, we can give a moment for people to come off mute as well, if that's easier. I did just want to mention, as we are approaching the holidays, this is a really great opportunity to remind your patients to chat with their families about their family history if they're not sure, because as everyone comes together for Thanksgiving and all of the December holidays as well, I think that could be a really good opportunity to reinforce making sure you're up to date with understanding your family's history. But one question we get sometimes is if there's not any dysplasia, either the presence of or absence of, put on the pathology report, can people assume that there's not any dysplasia?
Okay, good question. So I think in some of those examples, I showed that the pathologist may say a tubular adenoma with no high-grade dysplasia or negative for high-grade dysplasia. So a tubular adenoma, which again is the most common type of colon polyp, by definition, it's precancerous. And it actually does have low-grade dysplasia. So it's assumed, and so very, very, very rarely will you actually see a pathologist say tubular adenoma with low-grade dysplasia, because a tubular adenoma by definition has low-grade dysplasia. So that is the reason we know that tubular adenomas are 100% without a doubt a precancerous polyp, because they're already in that part of the pathway where there's a slight dysplasia, slight amount of precancer. Now, these are not going to turn overnight, right? We typically say these take 10 years or so to really turn into cancer, but a tubular adenoma by definition has some dysplasia. I'll kind of piggyback that by just addressing hyperplastic polyps, because this is a source of confusion as well. Hyperplastic polyps are typically thought of as benign, meaning not precancerous. However, there are some exceptions, is that if a hyperplastic polyp is in the right colon, the ascending colon, the cecum, the location actually matters. And the reason is because hyperplastic polyps and sessile serrated polyps are very difficult to distinguish from one another under the microscope. So if it's a hyperplastic polyp in the rectum, we don't worry about it. It's never going to turn into cancer. But if it's a hyperplastic polyp in the right colon, in the ascending colon, it's possible that that's actually misclassified, and maybe that's a sessile serrated polyp. So there are some nuances that it can be a little complicated. So it's always important for everyone to kind of make sure that the pathologists and endoscopists are on the same page. Tammy, was that a hand raised or a mistake on your Zoom? Can't tell. But if it's a hand raised, feel free to come off Zoom and ask a question. All right, maybe just a mistake. All right, any other questions, anything in the world that comes up that anyone's wondering about? If you get any, if you ever have any questions that you don't know how to address, or you want to see more examples of different types of polyps or procedures, let me know. Was it helpful to see some of the pictures? Yeah, okay. All right. And if you have any other topics that you're interested in learning about, I'm always happy to share as well.
All right. Since it doesn't look like we have any other questions, we can wrap up for the day and give you all about 7 minutes back, but wanted to give another huge thank you to Dr. Jen Kolb. She, as I mentioned, was really integral in developing that polyp categorization guide that we talked about today and in our earlier trainings this year. So definitely, as a reminder, I recommend that you all have a copy of that printed out to easily refer back to. But if there's any polyps that you all are having trouble interpreting, always can refer back to your primary care doctor, endoscopist, pathologist you work with, as well as reaching out to us if you have any other questions. So thank you so much, and I hope everyone has a wonderful rest of the day. We'll send the recording and the copy of Dr. Kolb's slides within the next day or so. So thank you very much.
Bye.
Bye, everyone.
Take care.